Okay, so before I get started, I just wanted to thank everybody for joining me tonight. And I created this lecture just to answer some of the most common questions that we get asked regarding diagnostic testing for common equine diseases. There are going to be some breaks in between each lecture section where we can have some questions and do an answer session. We'll also have some time at the end of the presentation. So I'll go ahead and get started. Again, it's what test do I run? And of course, I've just chosen a few of the more common tests. So this is me. I am the equine medical director on the Antech Diagnostics division. And you saw that video. Anybody who came on before saw the video a little bit about us. And there's a lot of things that we do on the Antech division on the equine side. So the goal of this talk is to have a discussion on, first of all, making sure that we're getting the correct sample type for the disease of concern, and also importantly, how we're going to collect that sample, store that sample, and then send it to the lab. How long is that sample going to be viable? Because there are obviously times when we have a weekend or a holiday and that we have to contend with, and deciding whether that sample is even worth sending. And also decisions for which tests to choose when you do have limited options. So I'm going to address some of these questions of concern. So some of the important considerations that I think about would be, and people ask as well, is this going to change the treatment? So if we're running the test, is it going to make a change as to what I'm going to do with the horse? There's always financial constraints that have to be considered when we're trying to decide which test to run. Sometimes we can run everything. Sometimes we have to pick and choose. Ability to get that sample to the lab. Again, is it a weekend? Is it late at night, etc.? The timing of the results. By the time the result comes back, is it going to have a positive impact on how I'm going to treat the horse? Which tests do we choose to run? What sample type am I going to have to get for that test? How am I going to handle that sample? And then how are we going to interpret that test? So at Antech, one of the things that I wanted to highlight here is these are some of the most common sample errors. And, these can be frustrating both for the veterinarian, both for the people in the lab, for the owner, et cetera. So we really try to limit the number of, errors that we have. And I would say for us in our lab, one of the, some of the most common sample errors would be the incorrect sample type, whether you need plasma and we're getting sent serum or whole blood, et cetera. Poor handling, if the sample wasn't put on ice, wasn't frozen, just the way it's even collected and stored. Is it in an appropriate container? Does it leak all over the bag, et cetera? Timing of submission, like we talked about, if you pull a CBC on a Friday and send it in on Monday, you're probably not going to have accurate results. The wrong test ordered, so you're looking for one disease, but you choose a different test, and then again that can lead to frustration because you don't have the right sample, and just unable to then again interpret those samples, those test results. So the first group of disorders I'm going to talk about are endocrine disorders. I mean, certainly in the last 10 years, we've been talking more and more about endocrine disorders, and I feel like this is sort of an ever-changing field. We've gone from a lot of different recommendations on when to sample, how do we handle it, names of the diseases, et cetera. So the things that I'm going to really highlight are PPID, Cushing's, insulin dysregulation, and thyroid disease. I'll go through each one of these. So the first one is PPID testing. So here, what test am I talking about? The endogenous ACTH and insulin is what we'll talk about first. And so what do we need for that sample? You really do need plasma. It cannot be run on serum or whole blood. You really have to have plasma. we talk about a fasting sample, and that, that fasting sample is really like flake of hay in the stall overnight, that kind of thing. But there have been a lot of different studies that have shown ACTH being collected at different times during the day, fasted, non-fasted. I don't know that it makes a huge difference, but we still do recommend that you do get that, flake of hay overnight in the stall. If you're in a situation where you can't do it, I still think that it is worth, running that test for endogenous ACTH. Insulin we will talk about separately. You really do need to centrifuge the sample. When we first started talking about endogenous ACTH and insulin, the thought was that you had to collect it in a special tube, it had to be centrifuged within a couple of hours, etc. Now we know that it just can be in a purple top tube, but you do have to centrifuge it. If you are going to just let it sit upright and settle out, it's the red cells that are going to affect the sampling. So if you have to do that, you should pull off the plasma, let it settle again, and then pull a second time. It would be ideal if you can centrifuge the sample and pull off the plasma, and it does not have to be done within 2 hours. It just needs to be done. So as long as you keep the sample cool, if it's 5 hours later, that's totally fine. And as you know, at the end of this presentation, we will be giving away a centrifuge that you can take in your car with you. I do carry a centrifuge with me so that I can, centrifuge the sample. But again, it does not have to be done within 2 hours, but you should centrifuge. What about how do we store it? It really just needs to be kept cold on an ice pack. You don't need to freeze it unless you're pulling the sample and you're not going to be able to send it to the lab for a few days. Then I would recommend putting it in the freezer. But otherwise, as long as you pull the sample and you send it in on an ice pack and it's kept cold, that is, what is recommended at that time to have, a viable sample. Everybody knows about the timing of testing, and this has certainly changed over the years. And, initially it was definitely don't test during the fall. And then it was, well, if you test during the fall, we might actually see those horses that do have PPID because they get such a spike. And now we know that you just have to be careful and cognizant of when you're testing and know where those peaks are. And so it used to be more like, let's not test in September and October. And as you can see here in this graph, that really it starts to go up sometime in July or August. And if you're going to be testing during that time, you are sort of in that shoulder going up and then, or the shoulder coming back down on the other side. And you just have to be aware of that when you're trying to decide whether this sample, what adjustment range that you should use. I personally like to just sort of go right in the middle. If I'm going to test in the fall, I really try to test, in September or October. If I'm gonna not test in the fall, then I just try to avoid, I think, July and August, like late July and August are tricky, and late October, early November, I will go more November, December, or the following spring. And so I think you just have to really be aware of that. And then as far as repeat testing, if you've initially tested in the fall, then you should probably test in the fall again. You want to sort of compare apples to apples. What about the TRH stim? A lot of people are doing a TRH stim now, and I think that's a really great option, because sometimes we don't know whether you're going to have to come back and do the TRH stim, etc. Where we really think about the TRH stim is more in horses that you're sort of on that borderline where you're not 100% sure whether the horse may or may not have PPID, 15, 17-year-old range, sort of looking on the early side. Older horses, you may be able to get them with an endogenous ACTH, but I do know a lot of people that just start with the TRH stim. And, I've seen a lot of samples come through our lab, and sure, there are samples that you could have diagnosed the horse based on just an endogenous ACTH, but because it's high enough to be that, but there are others that if you did not do the TRH stim, you could miss. So what is that protocol? You're going to, it's plasma again, so no different. You're going to collect the pre-sample. You're going to follow the ACTH procedure, which is the injecting 1 milligram of TRH intravenously, and then you're going to collect a post sample exactly 10 minutes post injection. And when I say here the handling of the TRH is important, you want to make sure that your actual TRH is viable. Otherwise, you're not really sure whether the test is going to be accurate. So if you are getting a larger vial and you don't use TRH that much, it has been recommended that you can pull out 1 ml aliquots and freeze them and just take them out as you're going to use them. The TRH should not be subject to heat or extreme cold or anything like that, or just rolling around in the bottom of your truck, etc. I have had instances where there's been confusion over testing, and when we went back and looked, that it was actually the TRH product that was the problem and how it was handled. So you just want to be cognizant of that. And we really don't have data at this point in time showing the TRH stim in the fall. It's still in progress. There's no exact data lines. We know that if you did a TRH stim in the fall and that horse was probably over 500, that seems to be where the cutoff may be, then you could be pretty confident that that horse does have PPID. But there is this equivocal range of sort of like 200 to 300 where we're not really sure if that is indicating that the horse has PPID or if that's just a product of the fall. So I do still caution, if you are going to use the TRH stim protocol, I try to stay away from the fall, but just understand, you know, those limitations. So for a summary on sample handling for PPID, again, fasting, I feel like that we do try to do that flake of hay in the stall overnight, but sometimes it doesn't happen. And I think you're still okay to take that sample. Plasma separation, it is important that it gets spun and not settled in a reasonable amount of time. And if you are going to settle, remember to do it twice. Storage cold, not frozen, unless it's going to be several days, then you can freeze. And we really don't recommend whole blood. You will not get an accurate reading. And the time of year, of course, is important for interpretation. All right, what about insulin dysregulation, which of course has lots of different names. It was IR, insulin resistance, metabolic syndrome, etc. But insulin dysregulation really probably is the best term that we use right now, and it does indicate what is going on, and that is that the horse is having a problem with their regulation of insulin, obviously. And so we used to always just do that resting insulin in that fasted state, again, that flake of hay overnight in the stall. The problem with this is it really does have a low sensitivity in horses that we think do have insulin dysregulation, because it's not always that at resting that horse is going to have a really abnormal insulin. More often than not, it's their response to ingestion of sugars that's the problem. And so yeah, if you get a really, you know, obese pony that has a resting insulin of 500 or something, that's pretty easy. But if you get some of these other horses, you can have horses that do have an insulin dysregulation problem and are not responding appropriately to ingestion of sugars. They can look like they have a normal body condition. Some of those just have internal fat. You can have those that are thin with the regional adiposity. And you can even have those that sort of look like they would be, but at resting without the challenge of sugar, they're not having a problem at rest. So we really recommend more dynamic testing, and probably the easiest test to run would be that oral sugar test. There are certainly more complex tests that can be run, but those are more, you know, clinic or research situations, and this is just very simple to run. So the sample that you're going to want for this is serum for insulin. And again, it's a field test, easy to perform, dynamic. And this is what the oral sugar test protocol is. It does need to be light Karo syrup. And this is the dosage, 0.5 mLs mils per kg. So that's about 75 mils for a 500 kilogram horse. And you could do it one of two ways. You could do a pre and a post. I do have people that will just, if they have taken a resting insulin and they already know that that is normal, they may just have the owner fast the horse from midnight onwards. And then the owner gives the Karo syrup by mouth with the dose syringe. And then you come to the farm and you could do a 60 and a 90 minute, or some people just do one sample 75 minutes later. And, you know, there's a chart for what that should be. And this at least is a more definitive test for, yes, this horse has inappropriate response to sugars, not that, you know, we're just taking a resting, because I think you can miss some horses that are going to have a problem with their ingestion to sugar, not so much just at rest. Okay, what about leptin? We certainly get a lot of questions about leptin as well in some of our endocrine panels. So leptin is a protein that's synthesized and secreted by adipocytes and is increased with leptin resistance. And you can, the sample for this is serum. I don't know exactly, I don't know that we know 100% how to interpret this. It seems to be that horses that have a high leptin that we know have an insulin dysregulation problem, or perhaps it's those horses that look like they have a fairly normal body condition, but they are carrying regional adiposity fat pads or even intra-abdominal layers of fat. Those horses can sometimes have a high leptin, and it seems that they are predisposed to having insulin dysregulation. So I do think that the information can be important as an adjunct. As a standalone, you know, we're not 100% sure what it means, and just high leptin levels alone don't mean a horse has insulin dysregulation. But again, it can help out. And where I find it the most helpful is for those horses that are not they are not obviously obese, but they're those ones that are a lot tougher, where they may even have a normal body condition, but it's the intra-abdominal fat or just that regional adiposity, and those horses can have high leptin. Okay, I'm going to move on to thyroid disorders. And of course, as you can see, like I'm just touching upon some of the main points of these diseases, because I'm really here to talk about diagnostic testing and not to really delve into, you know, the diseases themselves. So with hypothyroidism, you know, we know the definition is a deficiency in thyroid hormone, deficient thyroid gland activity, or a disruption in the hypothalamic pituitary thyroid axis. But this true endocrine abnormality of hypothyroidism is very uncommon in horses. However, we know that there are a lot of horses that are treated with thyroid hormone, and some are, you know, called hypothyroid, but they're not really necessarily truly hypothyroid in the sense of the definition. And so back to our, I'm sure everybody's excited to see these little charts here, but back to remembering how this all works with the thyroid. So thyroid stimulating hormone is secreted by the pituitary gland in response to thyroid releasing hormone from the hypothalamus. And so if you just are diagnosing hypothyroidism based just on the thyroid hormone concentrations, it's really unreliable, because you're not really testing the function of the gland. All you're looking at is really, you know, the end point. So the only way that we can really test the function of the gland, I will talk about in a minute, but we can look at the, you know, basic thyroid measurement. So if we do T4, you know, a lot of people will run T4, and that will include both protein bound and non-protein bound fractions. So we have to understand that it can have outside influences that may lower that T4. The most common one that we know of is like bute. You know, that could be one, but other things that can be in the feed or supplements or something can really affect our T4. Free T4 is the most active form of T4, and it's a much more reliable indicator of true thyroid gland function than just total T4, because we are able to see, as you can see in this picture here, that free T4 is showing the more active form, and it is not affected by outside influences like some of the resting hormones. And so monitoring horses on thyroid supplementation, if you're going to just measure these baselines, you really should be doing it about 2 to 8 hours after medication. We recommend the free T4, particularly by equilibrium dialysis. That's just the way that it's measured. So if you're just going to have one measurement of thyroid, that's the one that we recommend, is the free T4, because it is the more active form of T4, and it's about the closest we can get without actually testing the thyroid. So what about thyroid function testing? Why is this such a problem for us? The problem is that we don't have the availability of TSH in the horse to give the horse TSH to see if we are going to be able to stimulate the gland and determine whether the gland is functioning or not. And so the only test we really have available to us at this time without that availability is the TRH stimulation test. And so this, again, is testing not just the endpoint, but it is looking at function. And so you give the TRH, and then you're measuring T3 and T4 at 2 and 4 hours after injection of TRH. And normal horses will double at least double the T3 and T4. Clearly, the most difficult part of this is if you are, in the field, et cetera. It's not always practical that you're going to go ahead and give this and then come back at 2 hours and come back at 4 hours. In a clinic setting, it could be a little bit easier, or, this is the only way that you can test it. So if you really do want to try to test function, this is the only way we have at this point in time. So I just made this little sort of diagram here to talk about what, all the things that I've already mentioned, so that we could think about back to what sample do I need. So if we have serum for thyroid, and again, insulin and leptin. So serum is used for those three. And then plasma is ACTH, or the TRH stem, and that of course depends on the time of year, and the plasma needs to be cold, and you're going to spin or separate, etc. So really the only thing that we need for plasma is ACTH, but for serum we need insulin, for leptin we need insulin, and for insulin we need serum, and for thyroid we need serum. Okay, so in summary here, sample handling and time of the year are the most important factors related to diagnosis of PPID, as I mentioned. I do want to say that it is imperfect testing. Even with what we have now, I always say trust your clinical judgment. I do feel like there are some horses that, even though they look clinically like they might have PPID, and the ACTH is not, where you think it would be, I do think the TRH stim is more reliable, but sometimes they're early on in the disease. Other times we think that maybe it's not just the ACTH, there could be other things that are being elevated that we're not looking for, other tests that we're not actually looking for in those particular horses. So I do say trust your clinical judgment. If you have a horse that has chronic laminitis and long guard hairs, or they have muscle loss along the top line, et cetera, and you just can't get them to be positive on the tests that you're doing, sometimes I will go ahead and treat and see if they respond to treatment. Testing for insulin dysregulation really is best in a fed state or using the oral sugar test. And so if you are concerned about a horse, like let's say on a particular pasture or with a particular grain, I usually, kind of do your own oral sugar test where you have them out on that pasture and you come and you take your sample 60 and 90 minutes later, or that 75 minutes later, and you can then see what is their insulin to what they are actually ingesting, to that hay, to that grass, to that grain, etc. Or you can do the oral sugar test, which is much more definitive. It's a defined amount of sugar, and then you know what it should be. And baseline testing is just really unreliable for insulin dysregulation. Again, testing for thyroid disease is really difficult without the availability of TSH, and free T4 by equilibrium dialysis is the best option that we have for resting thyroid. And if you do want to test function, then a TRH stim can be used. So this is our first break for questions, and we'll hand this over to Beth.
Let's see, the first question is for the sugar test. When you say fast after midnight, is that a true fast or the one flake of hay overnight fast? If you give the one flake of hay, if the horse is usually on pasture during the day and no hay overnight, would you still give a flake?
I would not. I would do what they would normally have, but the reason that they did the one flake of hay overnight when looking at insulin is you would have some horses that were fairly frantic, not eating, and just due to the stress, the insulin would rise. So we do recommend the one flake of hay overnight, but if they're used to not having hay, then I probably wouldn't do the hay.
Very good. That is the one question I have so far.
Excellent. Okay, I will move on. Okay, respiratory diseases is the next section we're going to look at. And so I'm just breaking this down again. We're going to look at some of the common viral diseases, EHV1 and 4, influenza, rhinitis A and B, and then bacterial strangles. So, back to how are we going to do this? I think these are some of the things that we all think about, and I think they're really important. And that is when we're going to prioritize what diagnostic we're going to run for respiratory disease. Is it, a large barn setting or a small barn with individual horses? That's certainly going to make a difference as to how we feel that we need to get a diagnosis. If it's just 2 horses in the backyard, or you're worried about a huge boarding barn, that can have a difference. And, just looking at all these different diseases, obviously some of them might be more important than others as far as them being contagious. Also, which samples to collect, again, the financial considerations, what are the best collection techniques, how are you going to store that sample, and which tests to run. So starting with EHV1 and EHV4, so what are the normal clinical signs? Of course, what we worry about is, EHM, equine herpes myeloencephalopathy. But if it's in the respiratory form, we're going to miss it. Most horses have seen it by the first year of their lives. But you can see fever, lethargy, nasal discharge, and then again, plus or minus neurologic abnormalities. Why do we really care about these? It's really the neurologic aspect that is the most concerning, of course. Important facts is that viral shedding can occur for 10 to 14 days after infection. And I think it's important to have some of these facts when you're trying to decide, when you're going to test the horse, and you have windows for each of these diseases. So here, viral shedding is going to occur during that time. And sometimes a viremia can persist at least a couple of weeks. So you may have opportunities to get samples within a 2-week period of time if you thought things were going okay, but maybe now they're not. What's the diagnostic test that we recommend? PCR is certainly what we're using. And what sample do we need for that test? Respiratory secretions, we recommend a nasal swab. A Dacron swab is better than cotton, but if you have a cotton swab, and you could use that, or whole blood, and whole blood, of course, is looking for the viremia. Nasal swabs for this particular type of disease are more sensitive than a nasopharyngeal swab. So you don't really need to go way far up. You just need to get a nasal swab. And of course, you want to just try to get as much of the liquid that's, the mucus discharge, et cetera. And then you want to put it either in a plain red top or saline. Some different labs have their choice of preference. We send ours to UC Davis, and I think they prefer it not in saline, but it can go in saline. It just can't go into a culturette. And, we do get that, and that can be frustrating because you certainly can't do PCR once it's been put into culture media. And then whole blood, which happens during the viremia. So you have about a 14-day period of time. We generally recommend sending both of these in if you are concerned, because you don't know where you're catching the horse as far as the nasal shedding, how much are they shedding versus when it's in their blood. So we would recommend sending in both. What about serologic testing? The problem, of course, with serologic testing is that you have to, in order to have any validity and know what you're talking about, you really have to have a fourfold increase on samples 7 to 21 days apart. We usually are closer to the 21 days apart. So of course, if you have a horse and you're trying to treat them and decide what's wrong with them, waiting that 3-week period of time is certainly not ideal in your diagnostic period. So where I would say that serologic testing is most helpful for this disease would be that if you get paired serum samples from in contact horses who did not become ill, so you can see if they seroconverted, if they saw it, et cetera. Or you can also look for detection of, again, rising antibodies to screen for horses that were exposed to the virus. Where this is, to me, the most important is when you're dealing with an outbreak. Of course, EHM, is where we're thinking about the outbreak, and you're just trying to determine who's been exposed, who hasn't been exposed, those types of things. That's where the serologic testing really is helpful. But remember, you have to have a fourfold increase. That one-time titer doesn't tell you anything. All right, what about equine influenza? Of course, it's going to be pretty much the same signs, which, fever, lethargy, nasal discharge. What is the test we're going to run? PCR, respiratory swab, nasal swab, respiratory secretions, same thing. Dacron swab is better. It just absorbs a lot more of the fluid in their nose rather than a cotton swab. And you want to just break it off into a plain red top tube or with a tiny little bit of saline. But here you have a much smaller window of time. So peak viral shedding is only 2 to 6 days post-infection. And you may not really know when that infection started. Sometimes you can get positives all the way out until day 10, but this is where the peak is. And so there are times when I tell people, if they're really unsure and they just, I feel like you can always get a sample and throw it away. If you've gone to the farm, especially if it's a boarding barn or something like that, and there's respiratory disease, I'm always like, take samples, put them in your refrigerator. You can always throw them away, but you can't go back and get them from that time period that you might really need them. Because if a week later, several horses are sick and you're trying to determine what was going on, having those initial samples can be really helpful. Okay, what about strangles? I mean, here, I think is a perfect example. You see a young horse with big swollen lymph nodes and fever, et cetera. Those are not that difficult to try to figure out. Well, is that strangles or not? Either they're going to open an abscess or you're going to stick a needle in it, et cetera. But I think the ones that are much more difficult are the horses that are not clinically obvious like this, or the horses that have been vaccinated. So I'm just going to talk about all the different options and what you can do, because again, lymph node aspirate is obvious, but a lot of horses that we see now with the advent of vaccines, et cetera, we don't really tend to see as many horses that just are obviously strangles like this. So what are the options? Nasal swab, nasopharyngeal wash, guttural pouch lavage, lymph node aspirate, culture, PCR. We'll go through these. Okay, so talking about PCR first, what sample are the best if you're going to do a PCR? So a nasopharyngeal swab. So if you're going to do PCR and you stick a swab way back up into the nasopharynx, in an acutely ill horse, you'll get about 72%. Nasal passage. So again, acutely ill horse, maybe they have nasal discharge and you just take your little culturette and just go right into the nasal passage, about 79%. But the highest detection would be if you did the nasopharyngeal wash. And, that would be the best sample to do. The way that I do this is I sedate them. I use a uterine pipette. I pull up, good 20 mils of saline. I stick that uterine pipette up till I feel that I'm in the nasopharynx. They're hanging their head. You squirt the saline in, and then you catch all the stuff that comes back out their nose. Just remember, there's nothing really sterile about that, because obviously it's taking everything just from their upper pharynx and nasal passage. I've seen people collect it in a stainless steel bucket, in a rectal sleeve. There's all kinds of clever ways to catch it, and it's that liquid sample that you're going to send in. Okay, what about, culture? Obviously, directly from the abscess is certainly the highest detection rate. If you are going to do culture and you have an ill horse, it's really low detection rates by just doing a nasopharyngeal swab or even a nasopharyngeal wash. However, if you do 3 consecutive nasopharyngeal swab cultures or washes, it did increase the sensitivity, but you got to do it 3 times. So, that's where when you're trying to make your decisions, if you don't have a large abscess that you can get a sample from, I would say that you're much better off doing PCR, because if you just send it in for culture from just a swab or something, and it's got such a low detection rate, you could miss that horse that really does have strangles. Maybe it's hanging out in the guttural pouch or something. So again, both PCR and culture would certainly have the highest sensitivity. And when time is a factor, back to that, big boarding barn or something like that, where you're really worried, like this is, does this horse have strangles? Am I going to be worried about closing down this barn? Doing a PCR on 2 different upper airway samples, so a nasopharyngeal wash and maybe a nasopharyngeal or nasal swab, et cetera, is the best option, and sending both of those in. But one of them needs to be a nasopharyngeal wash to identify as many positives. Okay, moving on to Rhodococcus equi. Again, young, fever, usually this is weanlings, et cetera. You're going to see the typical respiratory signs, plus or minus nasal discharge. I would say in the cases I did my residency at University of Florida, we saw plenty of Rhodococcus equi. Most of them did not have a nasal discharge. It was more of a dry cough, et cetera. And there are really several tests that are needed for an accurate diagnosis. So cytology, if you do a tracheobronchial aspirate and you do, cytologic evidence on airway inflammation and Gram stain, is the quickest way that you can get a diagnosis, right? They have a very characteristic appearance, the organism. So that would be like really quick, we'd send it in for cytology and Gram stain. You have a pretty good idea that that's what it is. But it is still important, even if you do know based on that you do a culture, because it can, first of all, identify, are there other bacterial pathogens? And second of all, the susceptibility testing, because there has been more resistance to Rhodococcus, and you really want to know what your susceptibility pattern is. So we do recommend that you do cytology, Gram stain, and culture. You can do PCR on the tracheobronchial aspirate, but it really shouldn't replace culture, because as I said, you're not going to get identification of those other bacterial pathogens, nor will you get the susceptibility testing. It's just, it's going to tell you organisms there or not, but it won't give you that added information. What we don't use is serologic testing. I think, there was a long time ago people were using this, but it really, The problem with serologic tests and why we don't recommend them is that there's a lot of exposure and they can't really tell whether it's antibodies that are maternally derived or those that are produced by the foals. So we just really don't recommend it. So back to my little pictograms here. So for respiratory disease testing, really the only time you're going to need serum is if you are going to look for EHV as far as the serologic testing in contact horses. Nasal swab for PCR, influenza, rhinitis, and EHV 1 and 4. I didn't really talk about rhinitis A and B separately, but it's, would show the same clinical signs as some of the other respiratory diseases. And I would say that most places have a respiratory panel for PCR. We do in our lab, and it's going to include all of these, the influenza, rhinitis A and B, HV1, et cetera. And then when are you going to do with a nasal swab the culture for strangles? But remember that it's a really low sensitivity. So I don't usually recommend that. I would certainly recommend more of the nasopharyngeal wash and sending that in for PCR to look for strep equi. And the last one would be whole blood. And that again would only be if you were looking for EHV1 for viremia. So one thing that I didn't mention, and I'm going to just mention it here, these are all one-time samples that I talked about, but, the consensus statement from ACVIM from many years ago from talking about strep equi was that you needed, if you had a horse that you diagnosed as positive and you were then for strangles, and then you were then trying to determine whether they still had the organism, the consensus was that you would need to have a sample 1 week apart, like a nasopharyngeal wash PCR negative 1 week apart for 3 samples. And that's a lot, it's a lot of testing, it's a long period of time, et cetera. So ideally that's what we recommend doing, but I don't, some people will or will not follow those guidelines. So again, as just to recap, for sample handling, for the nasal swab, you really want to collect a Dacron or a cotton swab. You want to place it in red top tube or saline and keep it cool. For the nasopharyngeal wash, you want to place the fluid in a sealed container and keep it cool. Just make sure you tape the lid or something. And transtracheal wash, same thing. You can place it in a sealed container or a plain red top tube. If you've got some, really good stuff, I recommend that you make some slides if you have some thick discharge, and you could send in the sample plus the slides. I try to keep that cold. And whole blood, EDTA for PCR, just keep it cold, and it's good up to 7 days. So now I'm going to stop for questions on respiratory disease testing before I move on to gastrointestinal diseases.
Okay, Dr. Polkes, the first one is, I just got a nasal swab PCR positive for strep equi zoo, and the culture final does not. What do I do with that? And
the culture final, what was that?
It does not. I guess it did not identify anything.
Okay. I mean, I'd obviously need to look at the culture, but remember, so strep equi zoo would just be regular strep zoo. So it would not be strangles. That would be, that would just be the normal organism that would hang out in the upper airway, which of course does cause respiratory disease. It can cause abscess lymph nodes. It can cause pneumonia and all of those kinds of things. But I guess whoever's asking that question, maybe you can reach out to me separately so I could look at the culture and see exactly what you're talking about. But it is strep equi zoo would be just strep zoo.
That is the one question that has come through.
Excellent. So either everybody is sleeping or I'm doing a really good job of covering everything you need to know. All right, so moving on to gastrointestinal diseases. I'm going to talk about Salmonella, C. diff, C. perfringens, Potomac horse fever, and coronavirus. So same thing, of course, with gastrointestinal diseases and things that are highly infectious like salmonella, et cetera, you are going to prioritize diagnostics based on whether you're talking about a single horse in a small barn versus a large barn setting, you know, financial concerns, all of those things. So what about salmonella? It's certainly the most frequently diagnosed in equine diarrhea, and it can be difficult to diagnose. You know, what are the clinical signs? It can happen in any age, diarrhea, and it could be pipe stream diarrhea. It could just be soft stool. You know, you can't have chronic salmonella where they actually have normal manure, but I think we're talking more about, you know, a clinically sick horse rather than a horse that's just shedding it, and plus or minus a fever, back to is that horse sick or not. So when we're talking about culture, really you need a minimum of 10 grams of fecal material. And this goes back to samples that get submitted to the lab. If you just do like a little swab of the rectum or something and we don't have enough fecal material, it makes it difficult to get a diagnosis. And so they're certainly, the organisms are more consistently shed in form stools. So sometimes you do have to wait till it becomes cow pie or something like that. I have done a little technique when we were, you know, did it mostly in foals, et cetera, that have really watery diarrhea, where you can collect it in a plain red top tube, and you just have you know, enough in a plain red top tube that you could hope that you're going to get enough fecal material in a large tube that would help you to get the diagnosis. But if you're going to do culture, you really need to have multiple cultures. 5 cultures is what's recommended, at least 12 hours apart. But remember that those samples are not good for more than 48 hours. So you can't save your samples 5 days in a row. Even if you're doing the 12 hours apart, you're kind of, you can't save them all, because by the time they got to the lab, those first samples probably wouldn't be viable. And of course, you know, you can get a positive on the first one, but I've had them before where I got 1 positive out of those 5. So we do know that they can have inconsistent shedding, and you need to do multiple cultures. If you are really having difficulty or concern, or the horse really has watery diarrhea, you can take a little rectal biopsy, so a little pinch of the rectal mucosa, and you could submit that, and that will substantially increase the sensitivity. And so, you know, fecal culture does have a low sensitivity for, you know, looking at shedders in the equine population. So we're really talking about the acute horse. What about PCR? Certainly, for PCR testing, you would have to do 3 serial samples are recommended. So not the 5, but 3. What is the good part about this? It's a rapid turnaround time. It's higher sensitivity than culture, but it doesn't allow for further identification or susceptibility testing, just like we talked about with PCR. And then some people think that it might be too sensitive, live versus dead organism. Is it an active infection, et cetera? But certainly, I think PCR is a great option. You just have to know that if you are running again, these common, you know, fecal panels, and you're running one, but you really suspect that salmonella could be the culprit, and you don't, everything comes back negative, including the salmonella, just remember you would have to run 2 more samples of just salmonella to be accurate on the PCR 1 time, unless you get a positive the first time, of course. What about C. diff? You know, clinical signs, any age, diarrhea, plus or minus fever. You know, of course, all these colitis cases, everything can look the same. It's impossible to differentiate between them clinically. So we do have to think about, you know, risk factors. If the horse has been treated with lots of different antibiotics, you know, first they were on this one and then changed to this and changed to this, I would say C. diff would be pretty high on my list, because we know that antimicrobial treatment, changing it can definitely lead to Clostridium diff. And so the way that we are, I'm sorry, I'm going to go to Clostridium perfringens now. I mean, mostly we think about Clostridium perfringens when we think of foals. It can happen in any age. They can have diarrhea, plus or minus a fever. But it really has been identified in adult horses as well. There's some thought that it could be like that colitis X, where they get a peracute colitis and oftentimes die very quickly. Where's the location? Is it in the colon? Is it in the small intestine, et cetera? So although I really think about Clostridium perfringens much more in a foal, it certainly can cause problems in an adult horse as well. So how are we going to diagnose this? The ELISA toxin assay, and this is really important, is that you need feces in a container, not a culturette. Back to some of the sample handling problems that we encounter is sometimes people are, because it's a fecal, they are thinking culturette, et cetera, that sometimes we get samples that are submitted in a culturette, but we need just a fecal sample. And for C. diff, it's going to be a rapid detection of toxin A or toxin B. That's the most reliable test. Same thing for C. perfringens. So it's an ELISA, so it's pretty quick, and you can get your results back within a day or two. What about the PCR? Same thing. They're still looking for the toxin. They're not, looking for the organism. They're looking for the toxin. You still have to submit it in a container, not in a culturette. And so either one, it's just that depending on the ability to get it to the lab, how quickly you have a turnaround, you can do the PCR or the ELISA toxin. What about Potomac horse fever? I know there are people all throughout the country that are on this call, but here on the East Coast, we did see a lot of Potomac horse fever last year. And these, the clinical signs can be very varied. And I think they can be tricky because a lot of times the first sign that sometimes people will see will be, unfortunately, laminitis. I think diarrhea does not happen that often. It can or not happen. I know we're talking about, gastrointestinal, of course, but with diarrhea, some of the horses don't have diarrhea and they do have a fever, but sometimes by the time you notice that the horse is having a problem, they may or may not have a fever at that time. I think this particular disease is more difficult to try to figure out where day one was, because a lot of horses just have non-specific signs. Maybe they go off their feed or they're laying down more or something like that, and they're not showing an overt, illness that you can pinpoint. And so there's two diagnostic options for Potomac horse fever: PCR or blood. And it is more likely to be PCR in whole blood or feces, but it is more likely to be detected in whole blood before and for a longer period of time. And you could see down here, just keeping this in mind, that they're PCR positive in whole blood for a longer period of time and a little bit earlier than they are in the feces. But if you don't know where that time period is, it's probably best to just run both. So in our panels, every time we are doing the diagnostic testing, we do recommend that you send in whole blood and feces, and we run both because you're not sure where you are in that disease process. Serology really has a very high false rate of positives when you get a single sample, and you need that paired serum sample. Back to the same thing with the EHV. And so serum antibody titers they correlate very poorly with active infections. So you can't just look at the titer and say, yeah, this horse probably has it or not. You got to have a rising titer, et cetera. And it's just not practical when you have a sick horse. So we definitely recommend PCR. Coronavirus, I think coronavirus has become more prevalent in recent years. And this, again, very nonspecific. Any age, some have fever, some have anorexia, some have diarrhea, some don't, lethargy. You can see it in an individual horse, or we have seen farm outbreaks. What is the diagnostic test? It is PCR, same thing, feces in a container. Yes, most of these are contained in a fecal panel, but you can get them run separately, et cetera. Fecal shedding can occur anywhere from 3 to 9 days, and it can actually shed much longer in some cases. There was a recent report that there was a horse shedding like over 30 days. So they really can shed for a long time. And again, it could be both a single horse or an outbreak. And there are questions like, do you want to test in contact horses? Maybe there are horses that are not showing any clinical signs and are positive. I don't know what you would necessarily do with that information, because there's not, a definitive treatment that you're going to give them, but it could give you an idea how many horses might be affected at that particular farm, or is it an individual case? Lawsonia, I mean, Lawsonia is one of those diseases that I think, has almost pathognomonic signs. I'm sorry, it does say any age, but this is in a yearling. You're going to see fever, not yearling, weanling, fever, anorexia, lethargy, plus or minus diarrhea. These, horses generally have very, very low protein. So you see edema, their head is swollen. Again, they're in that weanling age. It has been diagnosed in adult horses, but it is most oftentimes in the weaning period. And this is the one test where serology is really, really helpful. And so this very particular test that really accurately determines the presence of antibodies, it has a very high sensitivity and specificity. And you can serologically test herd mates to see if they have been exposed or not. There is also a PCR test. Again, this is done on feces, not a culturette, but there is very low shedding in the feces, and it can be poor detection. And if you've treated them with antimicrobials, even worse detection. So it has a poor sensitivity, even though a high specificity. And they don't recommend that you do PCR testing of herd mates. You should really do serologic testing, because the healthy herd mates are rarely going to shed this. So you're going to see them as negative. But if you did the serologic testing, it could be more helpful. So again, to my little diagram here, the only time you're going to ever use serum for gastrointestinal disease would be to test Lawsonia. If you are going to take a fecal sample and send in for PCR, these are, most panels will have this: Clostridium difficile and perfringens, coronavirus, salmonella, Potomac horse fever. It may include other things as well. If it's for a foal, rotavirus, all the, other diseases. Fecal, if you are going to do an ELISA, that would be the Clostridium difficile toxin assay and the perfringens toxin, and for culture, salmonella. And whole blood, the only time you're really going to need whole blood would be back to that PCR for Potomac horse fever. But remember, if you're looking for Potomac horse fever, I always recommend that you send a fecal and whole blood, so that you make sure you have a higher range of being able to detect it. So now I have some questions. Thank you guys for hanging in there. I have one more short section, but if anybody has any questions on gastrointestinal disease, I'm happy to take them.
There is one question, Dr. Polkes, and it is, can you use a uterine culture swab for rectal mucosa cultures on an adult salmonella suspect?
A swab?
A uterine culture swab.
Yeah, I mean, if you're going, the problem is if you're going to submit a swab, then it's just going to be a low amount of feces. They really want a minimum of 10 grams of feces. So you're not going to really get 10 grams of feces on that. So I think you would have a pretty low detection rate as far as that goes. As far as if you were going to take use a uterine biopsy to take a rectal mucosal sample, which is what we do when we're doing a mucosal biopsy, rectal mucosal biopsy, that would be a much higher volume. But sending in just a swab is oftentimes not enough fecal material to get a diagnosis.
Gotcha.
Okay, moving on to the last section here. Fever of unknown origin. And of course, there's lots of causes of fever of unknown origin, but I am just going to touch upon some of the things that we think about. Certainly with respiratory disease, think about viral, bacterial, tick-borne. In the horse, there's really only 2 tick-borne diseases that we think about or know enough about to test for, and that would be anaplasma or Lyme, Potomac horse fever, and coronavirus. I think these are some of the most common that would have clinical signs that we couldn't necessarily pinpoint. So For anaplasma, PCR is the test. Usually there could be exposure to a tick, but you don't always know. Usually they have a pretty high fever, like 104s, 105s, that kind of thing in our area. And, on the East Coast, Maryland, Virginia, New York, Connecticut, et cetera, we see these, sort of called tick fever, where they get these just really high fevers. They generally get lethargic or anorexic, probably coming more from the fever than anything. And so PCR is the best. Sample whole blood. Again, you don't know where you're in the process, but if you get that early on in the beginning when they have that high fever, that's your best time. And so back to taking that sample, and you can always throw it away. A PCR sample is going to last close to 7 days. And so if you go out to that, high fever horse, and maybe you're going to give that horse Banamine or oxytetracycline or whatever you're going to do, and the owner's like, no, I don't want any diagnostics done, I just recommend that you pull some blood. Sometimes I'll just say pull blood and a nasal swab, throw it in your fridge, because if now you're several days later and you want to determine whether, because now the horse continued to have fevers or isn't doing well, it's really best to have that initial sample. And then, of course, cytology, like whole blood smears, we will see these in our lab where they will report them out, but it's usually when they're very early cases, and our system will flag them, and a clinical pathologist will look at them and confirm that they have anaplasma, and then you don't really need the PCR because there you have it. What about Lyme? The serum multiplex, which is run at Cornell, is a great test. That's really the one that we recommend using at this point in time. And that is, this is their interpretation with the OSP-A, OSP-C, and OSP-F. And so again, these are going to be all the same kinds of clinical signs. And so if you're going to look for Lyme, that's the test that I would recommend. So back to fever of unknown origin, we've talked before about the respiratory diseases and the bacterial diseases, and then anaplasma, Potomac, and corona, putting that all together, having a fever of unknown origin panel. Many years ago, when I first developed the PCR panels we run ours through UC Davis, I did start a fever of unknown origin panel because I know there were a lot of people that were sort of frustrated by those horses that had these high fevers and nobody knew what to do with them. And so, put together a panel where you could just sort of like combine a bunch of different things, right? The possibility of something that could be gastrointestinal or tick-borne or respiratory. And so we do have a fever of unknown origin panel that does include, these respiratory viruses, includes strangles, it includes anaplasma, Potomac horse fever, and coronavirus. Of course, that entails a lot of different sample types, because you need a nasal swab for the respiratory, you need a fecal sample for the GI, you need a blood sample for the tick-borne, et cetera. So you do have to send in several sample types, but I think this is a nice way to look at a bunch of different sort of systemic diseases in one spot. And we also have like a little mini panel that just pulls some of those out as well. So back to my little pictogram here. Serum is the multiplex for Lyme. If you're going to pull whole blood for anaplasma, either cytology, blood smear. So you can always make your own blood smear, but most labs, they're going to make a smear, always going to have a smear. And then for PCR for anaplasma or Potomac horse fever, and then the nasal swab PCR for the respiratory viruses. And fecal would be the corona or the Potomac horse fever. And, again, this is why when we are doing our fever of unknown origin panel, we do require many, different sample types. The only thing that's not included in ours, because it's a PCR, is the serum, which would have to be done separately for the multiplex. So I really thank you guys for taking the time this evening to spend with me. I will take any more questions if anybody has any questions to ask me. And you can always, this is where you can reach me. I'm happy to answer questions after this. I think Beth is going to provide some information regarding some diagnostic testing options that we have. And again, I just thank you for taking time out of your evening to be here with us.